My name is Roxanne Thompson, and I'm the clinical director at the Institute for Attachment and Child Development in Littleton, Colorado. We are going to speak today about adult children who have attachment issues and reactive attachment disorders. We've gotten a lot of questions, and we are going to get through as many of them as we can in this hour or a little over probably. I will let Bev introduce herself and we will get started.
Hey, thanks, Roxanne. I'm Bev Baker White, and I'm the senior therapist at the Institute for Attachment and Child Development. And I'm absolutely thrilled that we have the opportunity to go ahead and answer your questions today. And I want to welcome everybody around the globe. We're having a lot of folks tune in and watch our webinars from actually around the globe. So thank you for everybody for watching, and keep the questions coming because we love to present the answers. So Roxanne, are we ready for our first one?
Let's get started. We have quite a few today, so we'll try to answer these the best that we can with the information that we have. So, not knowing people personally, we can kind of give a blanket answer so that you know that it's, not very personal, but hopefully it will be helpful to any of you who are watching this Fireside Chat. This is our third one. We're planning several more, so stay tuned because we'll keep rolling these out for you.
Okay. Our first one's about a 24-year-old. It says, my daughter and I are not interacting well. Graduating college, starting work in a town with no friends has triggered her anxiety, and she lashes out at me. I think I have PTSD. We both need help, but for now, how do I move forward? She refuses counseling. Well, number one, she's 24 and she can refuse counseling. If they're of age, they have to choose it. You can't force her into it. So that's a battle I would not choose. I would support her. But if she doesn't want to go, she doesn't have to go, and she won't go. The piece about being out of town with no friends, but she does have a job, it looks like. Perhaps she could connect with somebody at work. Maybe she could, go to a class of some sort that she's interested in, yoga, photography, meetup groups. But as far as moving forward, I would support mom to consider taking good care of herself to avoid post-traumatic stress disorder, meaning instead of talking to her like she's still a child, talk to her, giving her choices of, would you like to try this or this or this? And then don't expect an answer from her right away. Tell her, okay, I'll get back to you. So what you want to do is make life be on your terms and not on her terms, as it sounds like it may be right now. So you have to take good care of yourself with new kinds of boundaries. So a lot of our discussion today will be about boundaries, how to set boundaries with adult RAD children, because they're a little different and the communication is a little different on how you, how you present options to share the control.
Yeah, boundaries are really, I think they're really important here. Because as a child's always pushing boundaries. And those are just old patterns that have never changed as she became 24. Now she's a full adult. And so that relationship has to also change. It can't be an adult-child relationship. Really needs to be an adult to adult, even though she is your child still, but she's still an adult, and her decisions are hers, and that's really important. Bev and I were talking about this question, and we talked about changing the language from parenting to choices versus telling. When you have a child, you give them choices. And you tell them, this is what you need to do. You need to share the control in there. This is how you have a an adult to an adult relationship. So I think that we also talked about when we were preparing for this that the mom in this situation might want to try some EMDR counseling of her own, making sure that if she does feel like she has some post-trauma and she's having trauma reactions to the things that are going on in the relationship between her and her daughter, likely that's a very, very old pattern. And those are old triggers for her. They've been going on for a long time. And it's time for mom to take care of herself.
Right, right. So EMDR is one, eye movement desensitization and reprocessing. That's been around since the Vietnam War. Dr. Shapiro developed that. There's brain spotting. That's another form of treating trauma. Somatic experiencing is another form. So there are a variety of modalities out there to help treat your own trauma. So.
Yeah. Okay.
Roxanne, you want to go with this next one?
Sure. Okay. Somebody wrote in about a 23-year-old. Reactive attachment disorder is only one of my son's difficulties. Mood disorder, maybe bipolar. ODD, maybe emerging personality disorder. He recently had an episode in which he was actually delusional and went on to on a concentrated crime spree because he was invincible, and that was in quotation marks. He was engaged, it broke up. He latched on to another relationship that was an obsession. He needs longer-term residential treatment for young adults. Can you suggest such a facility? He was adopted from Russia at age 7 months, and thanks for your help. So this is pretty complicated, talking about several diagnoses all at the same time, and not unusual when we have children who have significant trauma, early trauma. So thinking about linking up to some of the mental health system, the mental health system in your community, getting into a group, getting into a therapy group, a support group. He probably does need to be hooked up with the mental health system in your community. Now, whether he will be responsive to that request, I don't know. Because again, just like this first one, don't know if an adult, a young adult, is going to want to continue with therapy or get into a group or take medications. That's always a really, really hard situation because we can never make an adult do anything because they're in charge of their lives. So need to find a really good psychiatrist who really understands trauma and also can give a solid diagnosis. Many times there are many diagnoses and they all copycat each other. There's different, they look the same a lot of times. So get a very good psychiatrist that knows trauma who can really kind of sort that out for him and for the parents so that everybody knows what the expectation is and so that they know what to expect when he continues to mature more, go into the workforce, get an education. What are the expectations there that he is going to be able to manage with or without medications or intervention?
Yeah, without an accurate diagnosis, it's hard to get accurate treatment because you're just wandering around in the clouds, you know, aiming. But if you get an accurate, solid diagnosis, then you can develop a solid treatment plan. But again, the 23-year-old has to want to do that. I use the search engine. I use Google. Some people use Bing. But I actually typed in the long-term inpatient mental health facilities for young adults. I put all of that in there and several places came up. So I did not copy the list, but if you actually put long-term inpatient mental health facilities for young adults, you will see a few resources, and at least maybe those links can get you started. The other thought is there are what are called consulting agencies. They're like placement agencies, but and they charge a fee, but sometimes those consulting groups can help you find resources as well. I think that's all I had to add to that, Roxanne.
Yeah. I think and it depends also on your community and your how many resources you actually do have. You look at some of the more rural states, you may not have a lot of services. You may have to go to a surrounding state to be able to catch those services that you need.
Yes, we see that often, that, you know.
Even, and with kids, we see that.
Yes.
For sure.
We get a lot of questions from the UK, and I'm not familiar with the health system over there, but we'd like to address your questions as thoroughly as we possibly can. If there are any people watching the webinar that have more information for us about the mental health system in the UK, please feel free to send that to us, because then we might be able to integrate our answers for you better. So our next one is a 25-year-old. This says, what are viable treatment options for an adult with RAD? We have a 25-year-old adopted son that did not get the diagnosis until he was 15. We adopted him at 7, and he was with our family since the age of 3. He has not been treated for RAD as there were no options at the time of the diagnosis. He has very detached and dysfunctional relationships. He still has classic textbook symptoms. Again, we're going to sound a bit like a broken record because he's 25 and he has to choose treatment if he wants it. So viable treatment options, I think researching is fine, but if he doesn't want to research, he's not going to research. If you want to research, you can look at Psychology Today, you can look at attach.org. If you want to maybe get help for yourself, again, because of the trauma you've experienced from his trauma, you know, the trauma is so great that I think they try to put it on a silver platter and hand it off to the parents. It's like, here, this is too much. You do it for me. I can't do all this trauma. It's just too much. So, and then that in turn traumatizes the parents. So, support groups, we have RAD Advocates, which is a good resource group as well as support. If you look for support groups for parents, you want groups that are focused on healing and not rehashing the stories over and over. You want groups that have strategies and coping skills to help each other out. So again, this might pertain more to the parents than it does to the adult RAD child, unless the adult wants to get the help. And then there are resources. If you live in an area where there are no attachment therapists and there are basically no therapists familiar with trauma, you at least want to get started with a developmentalist therapist, someone who knows birth to 2, birth to 3, on and on through the stages of development, because that's a start. Because this attachment trauma happens, as we know, early on, birth to 3, and some people say 5, but at any rate, that's trauma. That's just stored trauma. But again, broken record, if they're of age, they don't have to get help if they don't want it. So take care of yourselves is what I'm saying as parents, you know, get support for your own trauma.
Yeah, and I think that's just so important for parents after the children have left home. In their adult years, you know, your identity has been wrapped around this child and trying to get them into adulthood. And that changes for parents. Their identity changes, their need to be needed changes. There's just so many things, but then you're still wrapped up a little bit in all of the chaos of the disorder, the mental health issues, needing, the child's going to come back even as an adult saying, I need help. And how far do you go with that? That really depends on what are you able to give and what is appropriate so that you are not enabling an adult who can, either make their own decisions or get into a system that will help them make their decisions.
Right, because they're working with someone who may be 25, but emotionally may be in an arrested stage of development or stuck at 8, 10, 12, 13. And
Yes.
so the parents then, of course, want to extend more help because they go, oh, 25 chronologically, but you know what? This is a 10-year-old out there in the world. So that's a little confusing, and boundaries have to get really clear.
Yes. Again, you're going to hear us say boundaries a lot when it comes to adult children and their parents. So.
And you know what? I'll talk about that as we go on what those, how to actually set boundaries, what we're talking about. There's physical boundaries, environmental boundaries, psychological boundaries, all that. So we'll keep talking about that as we go on further here.
Right. Okay, so we'll move on to the next one. This is about an 18-year-old. And the parent says, I wondered if you could give me some advice. I am a foster carer, have had a young man with me since he was 13. He is now 18 and has RAD. Before he was 18, we did get a strong bond, which was a shock to everyone. We had problems with boundaries, etc., but we got through them. And even though he played up, he respected me enough to do it. But since he has turned 18, all I hear now is, you can't make me do it. I'm 18. You're treating me like a child. And I can honestly say it's worse now, now that he's older. As most of the time, he still wants me to be mom. But on the other hand, I'm the one he disrespects when he's in a bad mood. And then just wants me to be, I don't know.
He wants to be a lodger. He just wants room and board.
Wants to be a lodger. Okay.
Mm-hmm.
Sorry, that one stopped me. And now I understand what that meant. But when he keeps trying to get my attention by doing things he knows I don't like, to just wind me up. Is there anything I can do? Because I know he loves me and wants my approval all the time, but he's going about it the wrong way. Can you help? Okay. So,
yes.
I have never heard an 18-year-old that didn't say this to their parents. I'm 18, I'm an adult, and I can do what I want now. The reality of that is that their brains are not completely developed, and they won't be for another 5 or 6 years. And they're still, the day they turned 18 didn't change anything. They have the same brain in their head that they did when they were 17 and pretty much when they were 16. So they're going to make those that's just kind of goes along with being 18. They feel empowered because legally they're an adult. I believe that this might have come from the UK, Bev.
Mm-hmm.
The writing here, and that's why I stumbled a little bit. Sorry about that. So I would just say that when a child turns 18, sometimes you go through those challenges with, I want to be an adult now, I'm going to emancipate, but they soon find out that they don't have the skills to go out into the world very successfully and still really need your help. So be patient with that. Don't take that personally. Just guide them through that. I'm 18 and I can do what I want to do. Sometimes they have to learn by natural consequences that they still don't know everything about the world that they would like to know. And we all did that. So it's okay. Just remember back to your 18th year. And what were you doing when you were 18? And I think you might be able to ride that through with them.
The trick on this one, I think, is that this individual is still doing the come here, go away attachment dance. And that makes it even more difficult because that has some emotional, what I call emotional abuse to it. And for the parents is to recognize that still is an attachment disorder, as I call the come here, go away dance. So you can't change your child, but you can change yourself. So you can change how you respond. I would say, if the adult child really can't respect the rules of your home, can't be respectful to your physical environment, your emotional environment, I would say try to help that child find another residence, either rent a room from somebody else or live with somebody else, just as a trial to let that person try out, to spread their wings a little bit and see what it's like. You may want to sit down and develop a budget with them before they try that, but at least give them a few skills and opportunities to do that if they're not able to be respectful in your home. Set up a few different scenarios to help them find their way. Choices of when you want them around. Let's say you found a room for them to rent and they still want to come do the come here, go away dance. You might say, okay, we're going to invite you for lunch. Would you like to come on Sunday? Would you like to come on Wednesday? Or is there another day you'd like? Now, the caveat here is do not expect them to answer on the spot. Just say to them, okay, we'll get back to you in a couple of days and see what you're thinking. And so when you call back in a few days and your adult child says, I don't know is a no. I don't know means no, I don't want to come to lunch. But I doubt that that's a response you'll get because it's food. And if they're out on their own, they probably want to come home for food. But at any rate, you get the drift of what I'm saying. Give them choices. That's, again, the choices. It's a matter of, again, changing the language, sharing the control, sharing the choices. But again, on your terms, you're still saying this or this or this. I will get back to you. And so you are still in charge of stopping your part of the dance. Okay, the child may still want to do the come here, go away, but you've basically taken over your part, which is good taking care of yourself. No.
So at this point, we want to stop and do a little psychoeducation with you on where the trauma is stored in the brain. And when you see your child, whether they be young or adults, or you or I as adults, anybody, if we've got some trauma in our background, this is kind of where the trauma reaction happens in the brain only. There's many more mechanisms that happen, but this is kind of the simple way to explain what you see when you see the fight, flight, or freeze, and that is the trauma response. So I drew my little alien guy up here, and so there's three parts of the brain that the only part that I'm going to talk about today with this is that I'm going to talk about the amygdala, I'm going to talk about the hippocampus, and the prefrontal cortex. So to start with, everything that we experience in our life is connected somehow to one of our senses. And all of that is stored in the amygdala. And it's just this little piece of your brain in the midbrain that's very small. And when I explain this to kids, I tell them that that's their computer chip in their brain, and that stores all the information. So we have touch, we have hearing, we have sight, we have smell, and we have taste. Everything is stored there. Okay. So when something in your environment triggers a response here because of something positive or negative, we all connect a song or a smell or a color. We can connect a lot of things to our experiences that we've had in our lives. So with our kids who've had a lot of trauma, if they smell something or see something or hear something, they see somebody walking down the street that looks like someone who has hurt them, or they pick up a smell of maybe alcohol on somebody's breath, or the way that somebody says something or a phrase. It could be any of those things. If you touch a child a certain way, it might be totally innocent to you, but it might trigger a response of fear. So what happens, this is the fear receptor here as well. So the hippocampus has to do with our short-term memory, okay? And the prefrontal cortex has to do with our connection to people and executive functioning, making decisions, being able to make a decision about anything in our environment, okay, that's happening. So let's just say that I just use one of those situations where a child is somewhere close to somebody, could even just be in a crowd or could be at church. That's not going to be a good one for church, but they smell alcohol on somebody's breath, but they could be at school, they could be anywhere. And some
Grocery store. Yeah, grocery store.
yeah, anywhere. So smell alcohol on someone's breath and they've been abused by a person who was drunk, whether it be physically, emotionally, sexually, it doesn't matter. It has a negative response. So this amygdala gets activated and it starts the whole process of this fear response and the trauma response. The hippocampus right here kind of shuts down its job and it starts to produce cortisol to try to come over here and help this little amygdala. And if it doesn't work, then we get cortisol all the way through and adrenaline all the way through the brain. It washes the brain and it pools right here in the prefrontal cortex. Now, in young children, we find that this will actually, if you have frequent situations where you have this trauma response and you have high levels of cortisol in the brain, it will actually eat holes in this prefrontal cortex. Remember, we develop from the brain stem over here this way. And this is the last place where development occurs. This part of the brain isn't even developed yet. And we're damaging it by trauma and the cortisol that is released and adrenaline that is released, and it stays right here. To get a child out of this situation, we have to get them into or anybody, a situation where they are not triggered into a calmer situation where they feel safe. So, and then those levels will come down and you can return to normal. Because this hippocampus is not working at this time during this trauma response, it will do you no good to ask what's going on and what the problem is. So don't even ask. The only thing that this person in this state needs is to know that you are there, you will not hurt them, that you can anchor them,
that they're safe.
They're safe, and that you can help them get away from the thing in the environment that's actually triggering this, whatever that is, if you know. Not sure that person can tell you always.
Right.
So if we can keep this in mind when we are dealing with children, young adults, any of us, when you see somebody who really is kind of having a meltdown, who's really avoiding, or they're just trying to get away from something, you know that this is a fear response. This is a trauma response. And if you can help them and understand them, then they can recover a lot faster. Instead of, yelling at them or getting mad at them or questioning them like crazy about what in the world's wrong with you, they can't tell you what's wrong with them at that moment. So I think it's really important to keep this in mind. This is very simple, very, very simple, but that recovery time can happen very quickly if put in the right environment. Children who come into care, a lot of times we like to do a cheek swab and check to see what their cortisol levels are. And a lot of times they will do these cortisol levels like 6 months out, 3 months out, 6 months out, 9 months out, something, to see if they're coming down once a child is in a more consistent and more nurturing environment. Okay, but what we're talking about today are adults, and adults go through this same thing. They will go through the same cycle, and so will you. Okay, a car pulls out in front of you and misses you by an inch, and you're going 75 miles an hour on the highway, you're going to have this response. Okay, it's survival. That's all it is survival. So let's keep this in mind as we continue to talk today about how to work with your adult children. And I'll leave this behind me. I'll move it a little bit, but I'll leave this behind me so you can keep that in your mind. Okay?
That's great, Roxanne. Thank you. I think that'll be very helpful for everybody. If we're ready, we'll move on to the one about our 18-year-old.
Sure.
Our transracially adopted daughter is DTD. I want to just announce to everybody who might not know what that means. That means developmental trauma disorder. So if you see DTD, it's developmental trauma disorder. And has now aged out of the latest juvenile group home. Well, she's still living there mostly, but now that she's 18, she comes and goes as she pleases. Trying to build an adult life for herself. She has a job, in parenthesis, an awful one, and friends, parenthesis, who are not bad, but who play the roles that she scripts for them. But she's in utter denial about her DDT or RAD or whatever people call me. We cannot let her live with us for many reasons, but we do want to help her toward healing and wholeness, and in practical ways too, as our boundaries will permit. She is done with family therapy and says, why can't we just live like mature adults? When we keep things superficial, we get along very well with her. How should we handle it when she pushes against our boundaries and asks why we can't just forget the past and be a normal family, in which she actively splits us and runs the drama triangle full throttle 24/7? I want to bring up the issues we need to work through, despite not being in a counseling environment. Yes, she will react badly, but then she will avoid us again for a while. My wife, and I'm not going to say her name, wants to insist to our daughter that we go back to family therapy to work through those issues, which would be great if our daughter participated. And if it were DTD informed therapy. And this person says not traumatic, trauma informed cognitive behavioral, which seems to be the only therapeutic approach in both foster care and juvenile courts. So your thoughts, I don't know where this question's coming from, but the thoughts are, again, at 18, you cannot force that. She still has chaos in her brain from her trauma. She's trying to emancipate. She doesn't have the tools, but at least she's trying. You know, she's thinking about it, trying to do it. This would not be the time to bring up the historical issues because she's not invested in addressing those. She basically says, why can't we be a normal family? Well, one, there's normal family, and you can't forget the past because the past is in your brain. It's already integrated, so that can't happen. So make the boundaries very clear to do life on your terms, not life on an 18-year-old terms. Again, another psychiatric evaluation would be in order if she would agree, or possibly a neuropsych eval if she would agree. Roxanne and I were talking earlier about her, and she could have other injuries. She could have closed head injury. She could have, fetal alcohol. She could have other disabilities that you can't see, okay? It would be good to rule those out. So I also want to know if she would qualify for mental health disability services. You know, if you had those evaluations, you could then decide whether or not she could apply for mental health disability services, and that would be a great help. But if she does not want to work on this or address the issues, this is not the time to bring them up. That's again, pushing against her trauma rather than trying to help calm her down. So again, you're gonna have to wait for a little while. I think the frontal lobe of that brain doesn't typically completely develop until around age 24. Could be wrong, could be a little older than that, but a lot of the studies say age 24 for that front part. So she just, if she's pushing against your boundaries, just hang in there, and there is no normal, so there can't be a normal family. You can't take the past out of yourselves, it's in there. And then try not to push against her trauma. So those are my thoughts on that. Roxanne, do you have some thoughts to add to that?
Yeah, I want to go back to some of the hidden situations that we just don't know about.
Mm-hmm.
Bring a child into your home that's, especially if they're, I don't know if this one said how old she was when she came to them. But if a child comes into care, you don't always know if there's been a closed head injury. You don't know, you're never going to know all of the trauma, all of the things that they've experienced. So, so you're never going to know what's going to happen here. Okay.
You don't know genetics.
Yes.
You don't know if they've got great Aunt Sophie or great Uncle Henry with a mental health disorder. You don't know that either.
That's right. So, children come into your home already loaded up with stuff, okay, with situations, with fear, with mental health issues. They come. We call that imported pathology, where a child brings everything, their own trauma into your home and into your family. And it's how you manage to keep yourself safe and work with the child. Getting that good psychiatric, maybe neuropsych evaluation is, I think, crucial. I want that to be done on every child that comes into care mostly, but we can't get it all the time. But we have to kind of make a case for that because it's expensive. But these are really important pieces to know. Also, the history of the parent. Does the parent have mental health issues? Did that mom drink when that child was in utero? All those in utero influences, domestic violence in utero. But there's just hundreds of factors here that you're not ever going to know all of them. So helping her, understanding her, getting her into the right place if she needs adult services, to be able to sign her up for that and help her move through that. I love it that she's got a job, whether it's a good one or a bad one. She's at least trying, which is a really good sign. So, you know, finding out all you can to help support her as she's trying to grow up is going to help everyone. Okay. Anything else, Bev?
I think that covers it pretty well.
All right, so we're going to go to the next one, and this one's pretty short. Like, what is the best medication for adults and older patients? Well, it depends on the diagnosis. Are we dealing with a mood disorder? Are we dealing with anxiety? Are we dealing with, you know, some of the schizoaffective types of disorders, the schizoid disorders? We don't know. And that's why you have to have a good evaluation with a good psychiatrist. I keep saying good psychiatrist, and I wonder why I'm saying that. Because not every psychiatrist really understands trauma and understands the kids who come through care, foster care, and who've been adopted. Even if they're adopted at birth, they were with somebody else first. And so there's a lot of grief and loss that sometimes is never dealt with. So And then when they're prescribing medications, you know, different ages need different doses, different types of medications. We don't want to give activating types of medications to kids who have trauma and are already activated because their system is still so high here because of their trauma. We don't want to make it worse. We want things to be stable. And that's what we do here at the Institute is we try to stabilize mood before we look at anything else, as we try to stabilize the mood for kids. So for older kids and elderly, it just depends on what the issues are and what the background is, and just find a good psychiatrist.
Yeah.
Sweet.
Really, you know, so kids produce a lot of their own chemical needs. And as we get older and into the elderly, we're not maybe producing as much as we need or something along those lines. So, so yeah, that psychiatric is so important. You know, you just really can't, again, I don't know how anybody could prescribe without a good diagnosis. So, okay. So adult RAD, when does it meet criteria for a personality disorder and how is RAD different from that? I love this one because reactive attachment disorder is on a continuum. We're all attached or not attached or somewhere on the continuum. If you've got a yardstick, we're on there, okay? It's about trust and intimacy, which allows us to do the bonding and attachment. So it does not automatically become a personality disorder. There are at least 9 personality disorders. And also in mental health, remember, it can be a mild case, a moderate case, or a severe case. So when you're treating, that has to be taken into account as well. So our brains don't automatically say the person's going to have a personality disorder. That, you know, it's they're what do I want to say? Are they mutually exclusive? They just doesn't necessarily happen. You know, can happen, but there's so many mild forms of attachment disorder that they're easily treated because, you know, they're treated a lot with post-traumatic stress disorder strategies because that's the basis of the attachment disorder is post-traumatic stress. So yeah, get the accurate diagnosis. The treatment's going to be varied, you know, based on the severity. The other thing is a person can have what we call features or characteristics of a disorder, which means they have some of the behavioral traits, but they wouldn't necessarily have enough to qualify for the disorder. So you might hear them say, a psychologist say, they have features related to that diagnosis. That's not the same as saying they have that diagnosis. Those are different. You still have to treat those behaviors, but it's different. It's not classified then as a disorder. So you may hear that features or symptoms similar to, but not necessarily having the diagnosis. A lot of times if you read a report, it will say rule out such a diagnosis. So apparently the person writing that saw some features or some behaviors that made them wonder, you know, and moving forward, they want to get an accurate diagnosis. You want to add to that? Oh, I know one other thing on that, like Roxanne touched on it earlier. A lot of the diagnoses have crossover behaviors. And so that's again why you want an accurate evaluation, because you'll look up one diagnosis and it has X, Y, and Z behaviors. You'll look up the next one, it has the same X, Y, and Z, but then it has other ones, but they do have crossover behaviors. Yeah, so many times they mimic each other. But the most common one that I think we see here is kids come into our program with a laundry list of diagnoses through the years, and basically it's a shot in the dark, I think. And so like ADD or ADHD and anxiety look almost identical in children. They do.
And so, they go through all that stuff at school and they take the Connors or some other evaluation through the school, and they come up with the diagnosis that a child has ADD or ADHD. And nobody ever looks at the anxiety side of this. So, and then stimulants are prescribed for the attention deficit, and that increases behavior. It does not help. It makes things worse. So we see that a lot here, and this is why I say get yourself a psychiatrist who knows what they're doing around trauma. And that goes for adults as well as for children. So I just, want to add that in, that so many times there's that mimicking of behavior, and it really helps to get that straightened out on what the real diagnosis is.
Mm-hmm.
Okay. And treatment depends on that.
Yep. So again, you have to understand the trauma.
Right.
Survival. Trauma is the survival strategies that they run on. That's the thing about our kids too. You can ask them why they behave in such a certain way, but they'll say, I don't know. And many times they don't know. It is the way that cortisol is released, and then they act out for survival strategies, but they're not thinking about that. There's no executive functioning that says, now I'm going to do this because this happened. They don't think, they just react. It's just a reaction. And so a lot of times they'll say, I don't know why I do that. And they don't, they really don't, especially if it's stored in the brain early on. So I would support therapists to hear kids closely to see if the I don't know is really an I don't know, or if it's an avoidance answer. But sometimes they truly don't know why they behave the way they do.
They really actually in the moment don't have any idea why.
They're not thinking. They're not using the thinking part of the brain, the executive function.
Because remember, things are shut down.
It's shut down, so it's not working.
Right.
Not working. There's a good point in there, Roxanne. We often say give the kids some cool down time, and parents will say, well, that's like them shutting down and walking away, and it's like, no, those are two different things. You got to have some time to calm down the cortisol. I say it runs around the brain like on a football track, and it's just got to get done, before it can come back to the thinking brain. So
exactly. Yeah. Yeah. That time, those times to just calm are really important. I have a colleague of mine who adopted 5 kids, and that was a sibling group. And one of the children is extremely reactive to certain things. And one day they were in Walmart, and all of a sudden he was fine. He was like 9 or 10. He was fine. All of a sudden he fell out in the floor and started having a tantrum and throwing things off of shelves in Walmart, screaming, I hate you, came out of nowhere. There was a reaction here on something in that store. Nobody knew what it was. Her husband, because he's really well trained in all of this, just kind of anchored him, stayed with him, said, let's sit down here on the floor. So they sat on the floor, and he was still screaming and throwing things around. People would come by and he'd just say, hi, how you doing? How you doing? Didn't react, kept things very calm. Didn't react to the child at all, just let him know he was there. And when he finally calmed, there was no getting him out of the store at that point. So you couldn't remove him. He had to work through it. So again, you keep things as calm as possible so that can resolve, because you never know if you can get out of that situation also. So this is a really important thing for you all to always remember when you even have adult children, that they're going to flare up every once in a while if they have not learned to deal with their emotions and deal with these feelings. They haven't learned to regulate it. So, yeah. Okay. And sometimes looks like another disorder. It just does. And it may not be anything but trauma. Okay. So here's one that it's a little bit long. So, but I think it's really important. Talking about a 20-year-old. Thank you for sharing these very informative fireside chats. As I listen, there are times when I think you are perfectly describing situations which my husband and I have experienced with my 20-year-old daughter. I can't tell you how many times we've heard that. My husband and I adopted our child from an orphanage in Kakistan. Somehow it doesn't, that word does not come out of my mouth, when she was 6 months old. In preteen and teen years, her behavior became more dangerous and risky. She had difficulty with peer relationships. She is immature for her age, and academics were challenging, so she was held back in school. She had girls who tried to befriend her, but she was an inconsistent friend and was always trying to be part of the cool group, who felt her neediness and took advantage of her. She was expelled from a Christian school mid-freshman year, then homeschooled, and then attended a Catholic all-girls school sophomore and junior year. Her online behavior became more and more sexual, dangerous, and risky. She ignored our rules as well as the schools. At the end of her junior year, she was getting around phone and computer restrictions. She was cheating, vaping, got fired from a part-time job, and had because she had turned 18, threatened to run away because she didn't need us to follow her rules, our rules. We kind of felt like we were living with a Jekyll and Hyde. We hear this a lot. When we were together doing something fun, we'd see a different person, funny, sweet, helpful, from the tough girl that lied and manipulated. In her junior year, we brought her out of a therapeutic boarding school in Montana. She was there for 21 months. She was doing her work initially, but then started to break the rules and faking the program. Lots of ups and downs. So she says there's always a boy. There was a boy she met online. She ran away with him, was gone for 7 weeks, called us when she ran out of money and had nowhere to go. She said, believe it or not, this is a short version of the story. And I just shortened it as well. We all know about attachment and delayed development in the frontal lobes that results in issues with impulse control, executive functioning, but it's heartbreaking to see her sabotage her life. Any advice or suggestions for us as parents? Okay, to start out with, she came out of an orphanage, and even if it is the best orphanage in the world, it would be rare if there was any kind of real nurturing and really attachment and real connection with a consistent caretaker. There may be many caretakers in an orphanage and many children who need attention all at the same time. So a child learns survival tactics. They learn to respond in a way of needing to survive. They perceive anyone that's trying to get close to them as a trigger. And again, if they've not had trusting caretakers, this is going to be a trigger. This amygdala is going to get activated, and we're going to go through the trauma response. So her running away, her not doing the rules, not getting close, that's all a response to what happened early on in an orphanage when she's very, very young. So that Jekyll and Hyde, that sounds very much like a mood disorder. You know, 1 minute they're high, 1 minute they're low, 1 minute they're happy, 1 minute they're sad. And so again, getting those really good evaluations is helpful. There are medications to help with mood disorders. there's no magic pill for RAD. It is just good therapy and treating the anxiety and the depression that pretty much go along with the reactive attachment disorder, which we find to be pretty prevalent with most kids and adults with RAD. But again, there could be other mental health issues there. So getting that help. There's a lot of drama going on in this family. And so the parents, she's only 18, I think. Was that 18 or 20? 20. So she is likely more operating on a 16 or 17-year-old, developmentally, socially. She has trouble socially. So you meet people where they are. If it looks like her developmental level is at mid to late teens, this is how you respond to her. Even though she's 20, she's out there wanting to be an adult. That sometimes is not a very good recipe for success or to keep yourself out of trouble. But to support her, help her, know what you would do for a 15, 16, 17-year-old is really important to understand that. Getting those good evaluations. Bev, anything else to add?
I just want to reach out to the parents who have biological children who end up having RAD, because it happens and you don't hear it talked about a lot, but it can happen. We've seen it happen if a child is born and they have to stay in the hospital without touch, maybe with test tubes and lights in their faces, and that's not every child's going to develop an attachment disorder or an attachment issue from it, but it's a setup for that to get in at that point. So a lot of times birth parents go, well, it can't be this because this is my birth child. Well, there are situations that can create that. Let's say you have a baby and you are so depressed you're not psychologically available. So you're holding your baby, but your baby can't feel you because you're absent emotionally. Well, that's a setup too for an attachment issue, okay? So there are situations in which birth children can develop an attachment issues or attachment disorder. It's specific to each birth and the first couple of years, but it can happen. So I just wanted to reach out and let birth parents know this can happen too.
The bottom line is being able to be in a situation early on that you can trust. If you can't trust your caretaker because you're completely 100% dependent on the caretaker when you're an infant, and if you can't trust that you're going to get fed or held or kept clean or warm or dry or not be alone, any of those things, those are basic needs for all of us, and those needs are not being met, a child will not learn to trust.
Right, and that's where the survival comes in. Okay.
Yes.
They're not thinking, babies aren't thinking this. They don't have the capability or the cognitive ability to think, oh, I'm not getting what I need, but they do feel it. They feel fear. They feel the anxiety. They feel sadness. They feel, okay? Can they think like we do? No, not possible yet. But can they feel? We all come in with those feelings. So those babies can feel. Piece of information there. So are we ready for number 9? It's pretty long. So let's give it a whirl.
Jump right in.
Okay. My son is diagnosed with attachment disorder and life was very difficult to the point he would present hostile behaviors toward me and to the extent he would put us in dangerous situations. Do you want me to read the rest of it there, or do you want me to go into my husband part, Roxanne?
No, you can go ahead for the next
Okay.
couple of sentences, 2 or 3 sentences.
Okay. Once he got to 10 years old, the behavior was too overwhelming. that he would exhibit all kinds of issues with me and not with my husband. I tried so hard to reinforce being a good mother, but life never got any easier. My husband never experienced the pain I went through with my son. I was always looking for answers, going to social services for help, but they failed us over a 15-year period, and the anguish continued. I went to my local MP. In the UK, MP means Member of Parliament, which is an elected representative in the area where they live. So she went to her MP, fought the education setting as her son was not coping in mainstream school, found funding for private school. Let's see. She did all she could do to get assessments, tailored therapy programs, family help. She did it all. Life was unbearable. Police incidents of my son running away from home, huge anxiety from the age of 10. The aggression got so bad towards me, I had to get a psychiatrist to give my son medication to help calm him. No one believed what I was experiencing. My husband and husband's family said it was my fault, and no professional felt compassionate to what I was going through. I got told it was his early years of trauma and to reinforce being a good mother, which I did on a daily basis. I felt alone and just had to carry on, feeling totally exhausted, holding down a full-time job. My son loved me dearly and would tell me, but he could not help pushing my buttons until he upset me. My husband and people outside the home would have the charming young boy. My son would not develop while living with us and would not allow me to treat him without exhibiting huge hostile meltdowns. My husband said it was all in my head, and we nearly got a divorce with all the stress and heartache. So do we want to read a little bit more there? With a foster lady, okay.
Yeah, that push-pull relationship piece.
Yeah. She learned about what we call the nurturing enemy, that as the mother, she's the nurturing enemy. I feel that I was not going insane and there are other moms in my position. My question to you is, as my son is in foster care, how can my son and I go forward to resolve the push-pull relationship when he does not reside with me anymore? Okay.
So he has moved into, we are assuming that he is not
Emancipated yet. I mean, this is the one where we were doing the math, trying to figure out how old he
we
is.
couldn't figure out the math. It's a math problem.
It's a math. It's a thinking word problem in math. So where do you want to start with that? He's still doing the push-pull. If he's not recognizing his behaviors, he won't want to change anything. I mean, I always say people really don't change until they get really, really, really uncomfortable. Life gets really uncomfortable for them. I see, and I say there are thousands of mildly miserable people walking down the street. Unless they get horribly uncomfortable, they're not likely to want to look at changing. So he's finding a comfort zone in his chaos, in his survival strategies, I think. So until he's able to take a look at that, I don't know how old he is. He's just, you're going to have to take care of yourself and how you relate to him. You're going to have the boundaries. And I would say, this sounds a little strange, but lower your expectations, until he can develop a little more. His cognitive abilities are not there yet, it sounds like. So I don't expect him to be able to answer your questions on the spot, because it's the nurturing enemy, the mother figure, that triggers the survival pattern, which puts him in a fear base, which means when you ask him a question, he's not going to be able to answer on the spot because he's not back up there in that part of his brain Roxanne drew so beautifully. There we go.
Beautiful.
Beautiful. Please, I say, get a good psychiatric evaluation. You want to rule out any mental health disorder that could be treated, because you just don't know. But don't expect him to answer you on the spot. If you're in that cycle, fight, flight, or freeze, there's not going to be cognitive thoughts coming out of your mouth. Yeah.
And I think another piece of this is that he is more relentless with the mom here, not with the father. And that comes from a child has a different relationship with the mom than they do with the dad. And with the mom, the expectation, even though it is pre-verbal, this is all pre-verbal stuff, is that when a child is in utero, that's their first home. That's their first smell. That's their first taste. That's their first touch. It's their first sight. It's the first thing.
Sound.
It's everything. And again, here we are. We get right back here to this amygdala. Okay. So it's all about the senses. And when that child is not getting what they need, there's that disappointment. Okay. Child does not know the word disappointment. They don't know. This is a sense of how they feel. And they feel that feeling about any mother figure because for fear that that mom is going to leave them because they no longer have that child in their care. That child has been separated from them. So that baby or that young child or even an older child, they have that sense of disconnect and do not understand it. It is absolutely something that a child cannot comprehend until they get older, especially an infant. Mom was here and now she's gone. And, that's what, there's a very famous book written a long time ago called The Primal Wound. And that is, it's so true. It is a deep cut in the emotions and the psyche of a child who have been separated from the birth mom. And so the moms are always the ones that catch it the worst. Always. Dads don't get it because the relationship is different. The expectation is different with that relationship for the father than the mother. So I think understanding that as well, and it is time for the father, when that is happening, to take the side of the mom and make it very clear that this is my wife and you do not have a right to treat my wife this way. This is where we ask dads to step in and support the moms in this, whether they see it or not. The moms don't make this stuff up.
No.
It's too intense for somebody to just make up. So dads, listen to your wives about how your children are treating them. It's so important to support them and not be split. That splitting happens all the time. Be on the same page with your wife.
Yeah, the kids have no need to demonstrate their survival behaviors to the dad because there's no threat of losing the dad, the unconscious threat. So they don't demonstrate, the threats that they give to the mom because they do threaten the mom. And the dad does need to back up and say, no, don't treat my wife this way. And we separate that out and say wife from mom on purpose because we want the child to hear that dad and mom are husband and wife so that dad has that relationship partnership with his wife. So it gives more support to his wife. And it's critical. It's critical because most dads don't see it. They just don't see it. And then they come home from work or wherever and the child has beaten up mom, either physically or verbally or emotionally. And dad has missed all that. And then the child is a little darling and superficially charming to dad and looking good, and mom's just collapsed on the sofa and she's experiencing oftentimes post-traumatic stress disorder. And so she definitely needs more support, not less. Actually, if she's at home all day with the child, dad can come home and he can take the lead and give her a break, let her take the back seat. And I did work with a family years ago where the two children had split mom and dad apart. So they divorced, then he remarried and they split the second mom off from him, the second wife. Okay, then he didn't remarry the next time, and eventually those kids gave him the attachment behaviors, the maladaptive behaviors. Eventually, that's what happened because he took over the mom role. So, yeah, it's just a difficult situation for the moms. So believe them, like we're saying, believe the moms.
We've had 2 kids come into our program this year where the parents they're not divorced or separated, but they're living in different houses. One has taken the child who has RAD, and the other has the other children in the home because the behavior is so detrimental to the other children in the home. We have families come to us where they're living in different houses in order just to manage this. And sometimes the kids go back and forth, depends on, they usually live within a few blocks of each other. So but they go back and forth, but they basically are living apart just to keep things calmer.
Mm-hmm.
And there's not that competition between kids for that mom, because kids with reactive attachment, any kind of attachment issues, are so needy. They need that attention, but don't know how to get it because they don't trust it.
Yeah, so demanding. They get very demanding.
Terrible cycle.
Mm-hmm. Mm-hmm. One of the things I want to support parents to take a look at too is when outsiders are looking at your family and they're going, well, it must be the mom. Let's say you have 2 children or 3 children or 4 children, and all the other children are doing really well. And then you have this one that's not. Guess what? It's not the mom. That's time to take a look at that child's history and get that evaluation. That's not the parenting. If you are successful with your other children, but you've got this one, then let's not point the bony finger at the mom. Let's just don't do it. Let's just get the evaluations done. Yeah.
I agree.
The moms. So it's just what the kids system does automatically. It's fight or flight. The triggers are there, unconscious or conscious, and that automatically kicks in for survival. And that's the thing to remember, that they're trying to survive and their trauma's kicked in.
Yeah, exactly.
So if you want to read more, Bruce Perry, Bessel van der Kolk, those are leaders in the field to follow.
Peter Levine.
Peter Levine, neuropsych leaders.
Yeah. You'll understand more about this very simple thing that I drew, my little alien up here.
Your alien?
Yeah, my alien. To really understand how to help your kids, whether they're adults or they're under 18, it doesn't matter. We all operate the same way.
Yeah.
And one thing that, Dr. Bruce Perry says is that trauma is not, the event that happens to a child. It is how they perceive that event. And you can have a sibling group and they perceive the events of their trauma in their home, in their birth home, or any other place differently, all different. It depends on their ability to be resilient and their ability to attach. And some kids are treated differently than other kids are treated. There's so many factors there. So it's how they perceive that event that means it's trauma to them. Might not seem much to you, but it was huge to them. So.
Yeah, threatened their existence.
Yes, yeah. Okay.
Well, that about wraps it up for me, Roxanne. How about you?
I'm good. I think this was a fun one to talk about, and I would appreciate your conversation, Bev.
And yours too. Thank you. It's always.
I didn't get to sit by my fireplace today. I had to be in the office today, so.
Yeah. So I would invite individuals, people, just please do send the questions in. We love doing our fireside chat. So let us hear what you want answered. And I want to say thanks, everybody.
Yes. And please just watch this within the next week or so. We'll have this put up on, there'll be a link to it on our website, and that's instituteforattachment.org. And then there'll be a link to these fireside chats, and they are on YouTube. So I think you can look at them from there too. You can look at them by just getting on YouTube as well. So thank you, everyone. And hopefully you'll tune in again.